RBC Consultants. Welcome to another International Dermatology Education Foundation educational series webinar. This evening, we're going to be talking about a new treatment for adults with severe alopecia areata, Deuruxoli. Our moderator this evening is Dr. Benjamin Unger, who is Director, Alopecia Center of Excellence, Director, Rosacea and Seborrheic Dermatitis Clinic, Assistant Professor, Department of Dermatology at the Icahn School of Medicine at Mount Sinai in New York. Our speaker this evening is Dr. Meena Singh, who is Medical Director, Skin and Hair Center at Overland Park in Kansas. We'd like to thank our supporter, Sun Pharma, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues, please submit your questions in the question chat pane on the right-hand side of your screen. At the end of this webinar, a survey will pop up and will be sent to you via email. We would greatly appreciate it if you could fill it in and send it back to us. And within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, if you have any questions, please submit your question in the question chat pane on the right-hand side of your screen. And I wrote a note there so you can know exactly where to type in your questions. And now, without further ado, I will pass the floor virtually to Dr. Unger.
Good evening, everyone. Benjamin Unger. It's really a pleasure to be here today to learn more about an exciting new treatment for alopecia areata. It's really a great opportunity to hear from an excellent speaker who will introduce us to the treatment and considerations when treating alopecia areata. You can go to the next slide. This is an event put on by the International Dermatology Education Foundation. Hopefully many of you are familiar with the IDEF. It's a nonprofit organization with a mission to raise awareness, improve dermatologic care all over the world, especially in underserved areas. And this initiative is directed exactly towards that, so that way we can improve care for alopecia areata, a disease that's frankly really undertreated. And so it's an opportunity for all of us collectively to improve the way we think about it and ultimately treat patients so that they can experience the benefit of amazing new treatments that may not be treated to the extent that's currently really necessary. Here are some examples of previous educational sessions, and please keep an eye out for information to follow the IDEF because there will be upcoming educational seminars as well. Here's Instagram, LinkedIn, Facebook, social media, website. So make sure to take a look and register for some really exciting and interesting webinars. And with that said, it's my pleasure to pass the virtual microphone over to Dr. Singh, who will really give us a great talk about Deuruxoli.
Thank you so much. Okay, just making sure you can hear me. I'm Dr. Meena Singh, very excited to be here to speak about LEQSELVI. It's the newest FDA-approved medication for severe alopecia areata in adults, and we're gonna go full speed ahead and keep it moving. So I'm gonna go ahead and get us started. Okay, so yes, I am speaking on behalf of Sun Pharma, and we'll be talking about LEQSELVI, Deuruxoli, like I stated, with the 8 milligram tablets. And this is not a CME program, but that's okay, we'll keep it moving. Okay, so LEQSELVI is a JAK inhibitor, and just like other JAK inhibitors, we do not want to use it in combination with other immunosuppressants or biologics. And so now that we've had more practice with JAK inhibitors and we have patients that are already on a biologic, or maybe they're on another JAK inhibitor, this is posed some kind of interesting conflicts. I have 2 patients currently that have psoriasis, arthritis, alopecia areata, and vitiligo, all 4. And I have to have these conversations where we decide which disease state do we want to focus on mainly, and which JAK inhibitor, which biologic, or which immunomodulator do we want to kind of choose based on the disease state that they feel they want to focus on more. So now that we're having so many patients on these biologics and kind of targeted immunosuppressants, these are conversations that you're going to need to have. And so specifically with LEQSELVI, you do not want to use this medication. It's not recommended with any other immunosuppressant or biologic. It is contraindicated in patients who are CYP2C9 poor metabolizers, and we'll get into that. Oh, we'll go backwards. Okay. So we're going to jump right into the box warnings. And just like our other JAK inhibitors that we've been using for alopecia areata, it has the same box warnings for serious infections, mortality, malignancy, MACE, and thrombotic events. With regards to increased risk for serious infections, the main thing is just making sure that our patients aren't active for tuberculosis or hepatitis. I live in Kansas City, and we have had a spike in tuberculosis cases over the last year, and there was considered to be an outbreak in our area. It was very interesting, you know, now that we're doing a lot of biologics and immunosuppressants. 2 years ago, I diagnosed 5 people with latent TB, and I'm one person in a derm clinic, and I'm, you know, purely checking for biologic initiation. And so if I could diagnose it, then, you know, there was a little bit of a spike. So we definitely want to make sure our patients aren't latent TB or active TB prior to starting these medications. And I'll just make a note on the side, but basically I do have these patients on JAK inhibitors. Basically what I did was get clearance with their primary care physician and or ID, and they're doing serial chest x-rays and or treated their tuberculosis before we initiated. So none of the patients that I have were considered contraindicated for treatment because we did address their latent or active TB. Okay, so with regards to the other box warnings, in a different JAK inhibitor compared to TNF blockers in patients that had RA, there was a higher rate of all-cause mortality, and malignancies specifically have occurred with LEQSELVI, and we'll get into that more. And with that same population of patients that were on another JAK inhibitor versus TNF blockers, there was a higher rate of MACE events, and specifically with LEQSELVI, there have been thrombotic events. Okay, so again, contraindicated with LEQSELVI are patients who have CYP2C9 poor metabolism. And so the reason is if they are poor metabolizers of CYP2C9, they have an increased risk of severe adverse reactions. And I have now tested plenty of my patients that we've initiated LEQSELVI on, and I have not had any patients that have been poor metabolizers. I have received intermediate, but I have not received poor. And if you do the test and you receive back intermediate metabolizer, that's perfectly fine. It's not a contraindication. It's only the patients that are poor metabolizers. All right, moving on. There was GI perforations can happen in patients that were on LEQSELVI. There can be laboratory abnormalities as well. We'll get into that. Specifically with regards to immunizations, it's important to kind of counsel your patients before getting started with LEQSELVI about potential live vaccinations, specifically shingles and other immunizations such as that. If they are someone that you think needs it, I would recommend just going ahead and getting it prior to initiation, because otherwise it's recommended to stop and pause the medication for 2 weeks if they're going to have a live vaccine. Regarding the dosage, and we'll get into this more when we go over the trials, but LEQSELVI is one dosage and it's 8 milligrams twice daily. Whether or not they take it with food, doesn't matter. All right, moving on. Okay, so just again, before LEQSELVI is started, we're going to check to see if there are CYP2C9 poor metabolizers or if they're on a medication that inhibits the CYP2C9 genotype. And then again, we're going to evaluate for tuberculosis, like we already talked about, hepatitis, like we already talked about. And then when we do their complete blood count, if they have absolute lymphocyte count less than 500, an absolute neutrophil count less than 1,000, or a hemoglobin level less than 8, it would not be recommended to start the LEQSELVI until those things are addressed, and then potentially circle back if those improve. We'll get into the adverse reactions when we talk about safety. And then if a patient is pregnant, it would not be advised to initiate LEQSELVI. All right, so we can talk about AA, although most of you guys know how AA works. It is a chronic autoimmune disease affecting anywhere on the body that has hair: eyebrows, eyelashes, scalp, beard hair, body hair. Some people, as we know, present with patchy multifocal alopecia areata. Some patients present with the ophiasis pattern. Others, unfortunately, totalis or universalis. It's a very unpredictable type of disease state where, there's no way to predict which patient will develop what presentation. It affects men and women the same and impacts all racial ethnic groups. And currently, the lifetime risk is around 2%. In the United States, around 700,000 individuals currently suffer from alopecia areata, which around 300,000 have severe alopecia, unfortunately. So these are real quotes from patients. I will say with my patients, the things that I hear, and I'm sure you guys are hearing as well, is just the difficulty in covering up the spots, looking one way and then a couple months later having a completely different way that they present themselves, getting bullied for it. Just reading one of these, the one on the bottom is kind of sad. It's sad when you see, I see people, the way people treated me with hair versus without hair, and it was a huge difference. I have a patient who had alopecia totalis, and she had it for 8 years prior to us having these JAK inhibitors available, and her children had no idea. Her children were young. She did not want them to think that she was sick or had cancer, and so she was wearing wigs for 8 years, and she was holding that burden and that internal stress and trauma without being able to show her real self when she got home. She was having to wear wigs even at home so that her children didn't have to see her hair in that state. So it does have a, profound psychological impact, which is the point of this slide. So, it's not just hair, right? Alopecia areata takes a toll beyond just the fact that you're losing hair. The eyebrows and eyelashes serve purposes. If you're sweating, if you're an athlete, you need your eyebrows, you need your eyelashes. The nail changes, the brittleness can affect how you handle, how your fingers handle. It can lead to psychological impact, depression, anxiety, suicidality, and it costs money. All these cover-ups, the extensions, the wigs, all these cover-ups can be quite expensive. So these are things that we need to think about because, I think as dermatologists, we are very focused on outcomes, right? We just want this hair to grow back. We're looking at efficacy, but the toll in between our visits, we need to be talking to our patients about that as well. How are they handling things? How are they covering the spots up? Do we need to help them with that? Give them suggestions. So these are all things that we need to talk about. In addition, I have patients who really have a lot of tracts in their hair because they're just covering up spot to spot. And I actually had a patient this week who had traction alopecia underneath her spots because, she had not seen a dermatologist yet, but she was trying to get into us and she was covering it up with extensions with the help of her hairstylist, and she was not aware that some of those tracts were not alopecia areata and they were actually traction alopecia. So these are just things that we should be discussing with our patients. Okay, so with that being said, as physicians, like I was saying, we're not the ones living with the hair loss. Early intervention is very critical, right? We talked about the cover-up aspect, but also for the efficacy aspect. We know that the longer that the patient has a certain duration of episode, the less likely it is for us to get meaningful regrowth. So if the episode is greater than 4 years, there's a significant chance that the response rate will be lower. And if their duration of disease, like meaning they've had a diagnosis with alopecia areata for greater than 10 years, also a reduction in the treatment response. These are things that we have to tell to our patients. And so just another patient this week, actually, just to bring this point home, it had only been 3 to 6 months that she'd had the diagnosis and that she'd even had alopecia, period, never had it before. And I was just letting her know that we're so lucky that we're going to be able to address it and treat it now because next year, the year after that, it might be more challenging, and we're not going to wait to see if the hair regrows. We're going to go ahead and treat it aggressively right at that moment. So these are things we need to be making sure and telling our patients they know. And then also, if we have a patient that maybe, got lost to follow-up or just kind of gave up on treating and is coming in now, they've had that episode for 5-6 years, we can just tell them that it might be more challenging to get regrowth, just to give them more kind of legitimate what to anticipate, basically. Okay, so I thought this was really interesting. So they polled patients versus providers about how important they felt the speed of treatment was. And again, as the provider, we're not living with the alopecia. So of course the patients, over 80% were like, yes, treatment response, the speed, we want that hair to come back as quickly as possible. But for the providers, it was only over the 70%. I think it's because maybe we're focused more on efficacy more so than speed, but the patients want speed. They want that hair to come back as quickly as possible to stop the suffering as quickly as possible. So that's really something important that we need to note for these patients. And then the other question is, why do we really need another JAK inhibitor? We have a couple already. Do we need other options? And there's an interesting slide just kind of speaking to that. So there was a study that showed up to 30% of patients were actually non-responders to JAK inhibitor therapy. So there is a gap in treatments. And another interesting point was that just because a patient failed one JAK inhibitor, that did not preclude them from having success with another or once they switched. So these are just important things to note because we already have a couple already out. Do we need a third one? Do we need another one on the market? And kind of, yeah, we do, because we've been, a lot of us treating alopecia areata for a long time, and just like it states, not every patient is going to respond to any JAK inhibitor the same. Okay, so let's talk about LEQSELVI specifically and its efficacy. So it's all about speed. So we talked about how important that is for the patients and meeting the need for speed. And we're going to talk about the efficacy results through 24 weeks. So this is kind of why you guys are here, right? This is the important slides. Okay, so how was it studied? LEQSELVI was investigated with 2 randomized double-blind placebo-controlled trials, Thrive AA1, Thrive AA2. The patients had to be adults, 18 to 65. They had to have a SALT score greater than 50, so considered to be severe alopecia areata. And this is very interesting because the current episode could go up to 10 years. And as we know, that's a little bit more challenging. So these are really patients that had significant severe alopecia areata. They looked at LEQSELVI 8 milligrams BID, the Deuruxoli 12 milligram BID, and then placebo BID. And we'll be focusing more on the 8 milligram BID because that's what's been FDA approved. Primary endpoint was achieving a SALT score of less than 20, so greater than 80% scalp coverage by 24 weeks. So, and we'll get to the other endpoints as well. Okay, so just a reminder about the SALT score, and I, to this day, still get it backwards because in my mind, the greater the number, the better the success, but obviously with SALT score, it's completely opposite. So the higher the SALT score, the more hair loss they have, so the lower the amount of hair on their head. So SALT score 100 means complete hair loss on the scalp. SALT score 0 means a full head of hair. Just a friendly reminder. But, with dealing with insurance companies these days, SALT score is not the only thing that matters. The percentage of scalp hair matters some, but there are other factors that can kind of elevate the severity of the alopecia areata. So this may be helpful, the AA scale, because it does factor in other things that impact the alopecia, but you start off with the percentage of hair loss. So still 50 to 100% is considered severe alopecia areata, but is the patient having negative psychosocial effects? Are they looking at you when you speak to them? Are their eyes kind of gazing downwards? Are they crying? Are they telling you how much they're suffering? These are things that can kind of elevate at a point in the AA scale to take up the notch of severity. If they have eyebrow eyelash loss, that'll increase the severity of the alopecia. And then I use this factor a lot when I'm deciding if I want to put a patient on a JAK inhibitor specifically, or systemic medication as opposed to just scalp-directed therapy. Have they responded within 6 months? And so if I have patients that have maybe multifocal alopecia areata and we're trying all these scalp-directed therapies, excuse me, and they have not had full regrowth within 6 months, and I tell them, okay, it's time to move on, because that means that you may be someone that needs a little bit more aggressive therapy or systemic therapy in order to get a response, meaning full regrowth. That's what we're hoping to achieve. And then how active is the hair loss? So if you have 60% scalp coverage, but the hair is coming out in clumps and diffusely, then this is a very active, kind of rapidly progressive alopecia areata, and this does take it up a notch as far as severity. So these are things that you can think about as a different approach besides just using the SALT score. Okay, very important. These are the baseline characteristics of the patients that were studied. Just note that the mean duration of the current episode was around 4 years. So again, we talked about that if a patient has had an episode for over 4 years, the likelihood of regrowth is going to be lower. So the mean duration in the patient studies were about 4 years. So that's important to note when we talk about the efficacy, that these were challenging patients to treat. They had almost 90% scalp hair loss, and of the patients treated or studied in this and with LEQSELVI, almost 60% of them had alopecia totalis or universalis, so near complete hair growth. So that's a high percentage of patients that were going to be very severe and more difficult to treat. Okay, so this is what you guys are here for. How effective is LEQSELVI? So around 30% of patients did achieve that clinical endpoint of a SALT score less than 20 by week 24. But the really important thing to note here, which is very interesting, by week 8, the study reached statistical significance. So there were patients achieving a SALT score less than 20 by week 8. So that is, that's very interesting, and that's something we're going to get into more. Okay, so this is a characteristic patient that was seen in the trial. Baseline SALT score 90 by week 24, full head of hair. It looks like a completely different person. Actually, this, besides the neck, doesn't even look like the same patient. So you can see the profound kind of impact on how the patient kind of presents themselves to the world. And this is one of those patients that had fast results. So they started off with a greater than 50% SALT score, so right around 50. And you can see those patches starting to fill in already by week 8, which is really important. So I had a patient just today, so I was really excited to share with you guys because I was doing this. And, I just started prescribing this medication just a month ago, so I finally got one back. She is someone who had alopecia totalis, and using a different JAK inhibitor, we got all her hair to come back. We have not stopped anything. We were doing everything the same, and her hair started coming out again in the ophiasis pattern. As we know, that's harder to treat. So I just started, and she also had rapidly progressing alopecia, so her hair was coming out in clumps as well. So we knew we had to be a little bit more aggressive, but we have not changed anything. Nothing about her has changed. So we felt that she would be a good person to switch to LEQSELVI to see if it would kind of turn things around faster for her. And I'm happy to say that within a month, you can't tell that she has hair loss now. So I've just this one patient, this is the only patient I've seen any difference yet, because I haven't really seen anybody back yet. I was very impressed that not only is her hair shedding, but you can't see the patches. So, and it was ophiasis pattern. So that was really interesting for my one patient that I have seen a result with. But, I've seen this data and I've heard about it. I had yet to experience it for myself. So I was very impressed in my N of 1 that I actually did see within 4 weeks regrowth and a reversal in the shedding, which was really interesting as well. So just a little clinical note that I have for my one patient that was so far so good, a success story. Okay, so again, visible progress fast. So I love this because, as you know, achieving a SALT score of less than 20 means 80% regrowth. But what about the patients that were not considered responders, but they had some regrowth? This is very interesting. So, and again, let's go back to those baseline characteristics. Mean duration of episode 4 years, and over 60% of these patients have severe alopecia, meaning alopecia totalis, alopecia universalis, and percentage, if I didn't go over this, but we go backwards, but it was around 87% hair loss mean in all the patients. So by 24 weeks, 50% of these patients reached a SALT score of around 50. So that is really helpful in our clinical setting, right? If we have patients, we're giving this medication 6 months out, we're not seeing anything, what should we do? Versus 6 months out, yeah, you don't have a full head of hair, but half your hair is back. That is something that's really, really, I think, helpful to see this data, because it's something that we can tell our patients, if we give you LEQSELVI and you have severe alopecia areata, there's a chance that, within 24 weeks that you could have at least half your head back, half your hair, not your head, half your hair back. And then this was really cool too. So these are the patients that didn't get the full, 80% regrowth within 8 weeks, but this is very interesting. 20% of those patients, again, severe alopecia areata, around 60% had alopecia totalis. 20% got half their hair back within 8 weeks, which is amazing. That's 1 in 5 got at least 50% coverage within 8 weeks. So I love that. It's so helpful for our patients to get any inkling of hope. As we know, when you have no hair in your head, at least you start to get some fuzz, some coverage, and either 50% of your hair back, that's a huge difference. Cosmetically, how you feel, you have hope, you're not as depressed, you're not as psychologically impacted. So very cool. And as we know, facial hair loss is just so challenging. For women, you know, we have eyelash extensions, we have other things we can do. We have fake eyelashes, we can draw our eyebrows on. For men, you know, that just doesn't even, it's not socially acceptable, and sometimes it just doesn't look right for a man to draw his eyebrows on or put fake eyelashes on. Like, there's not much really you can do. So it's helpful to have medications that actually can get your eyebrows and eyelashes to grow back. And you can see the profound difference in her cosmetic kind of presentation when she was baseline, not untreated, versus just 24 weeks later, she looks like a different person. So profound impact on how she's appearing. Okay, so that was the efficacy. Let's talk about the safety. So overall, it was a total of around 1,700 patients that were treated with LEQSELVI, representing over 1,900 patient years of exposure. And we're going to be talking mainly about only about the patients that were on that 8 milligram BID dosing. And so these are the adverse reactions that were reported in over 1% of the patients over that 24-week period. So this is the 24-week period, not the extended period. So what you would expect: headache, acne. And it's really interesting because, you know, maybe you guys can speak to this on your own. I can't speak back and forth to you, but I don't see a lot of the what we call jacne. And maybe I'm jinxing myself now, but I don't see a lot of it. I've spoken to other providers as well that say they don't see a lot of it, and I've spoken to some that say they see it on every other patient. So, you know, something to talk about with your patients so they know, you know, to take care of it. And it's just basically so they know that if they're developing acne, it's probably from this medication. And then the CPK. So CPK increases, you know, everyone has a different opinion about it. You're not going to check it at baseline, but I have had some patients on other JAK inhibitors get really sore muscles, and we've checked their CPKs, and it has shown that it's elevated. And so you can decide whether or not you want to treat through it. You can decide whether you want to pause medication. It's just up to you and the patient, and whether they're feeling like they want to pause so they can kind of recorrect, and how tolerable it is for them. Hyperlipidemia, we'll get into that. These are the things that we'll monitor for. Weight increase was seen as well. And it's really interesting because they pointed out herpes, and this is specifically HSV, not VZV. So that occurred as well. Okay, so adverse events of special interest, and these are parsed out 24 weeks, the placebo-controlled period, and then on the far right corner, this corner here, is the extended period through 52 weeks. And so 3 malignancies did occur, 1 non-melanoma skin cancer, no thromboses in this period, but there have been some that in the subsequent periods outside of the 52 weeks. Serious infections have occurred as well, and of course, laboratory abnormalities. So how does LEQSELVI work specifically? We all know what happens with alopecia areata. We have that swarm of bees appearance around the hair bulb, where we have immune complexes attacking the hair bulb and leading during the anagen phase of the hair cycle, and leading to the presentation that we see of the circular patches, ophiasis pattern, kind of slick, smooth hair loss. And that occurs because we have inflammatory cytokines binding and stimulating that JAK-STAT pathway of translocation to the nucleus, and the circular pathway where you have increased cytokines being produced, and that leading to even more stimulation of the JAK-STAT pathway and further hair loss. So how does LEQSELVI work? LEQSELVI is a JAK inhibitor that is more it binds more so JAK1, JAK2, and some TYK2 more so than JAK3. So you can say JAK1, JAK2, some TYK2. And by inhibiting that pathway, it just down regulates that cytokine production and that inflammatory production and decreases the that kind of swarm of bees appearance around the hair bulb. And targeting this JAK-STAT pathway will then lead to hopefully healthy anagen cycling. Okay, so we need to get into this. It's very, very important because you actually need to be checking for this before starting your patients on LEQSELVI. So LEQSELVI is influenced by CYP2C9 metabolism. It is primarily metabolized by CYP2C9. Again, we talked about that poor metabolizers or patients that are on medications that inhibit CYP2C9 are at increased risk of possible adverse reactions. Only about 1 to 4% of the population are poor metabolizers, but it's something that we actually have to check in order to initiate the medication. Okay, so LEQSELVI is twice daily. You do not have to worry about whether you're taking it with food, without food, the 8 milligram dose, and you do not have to make adjustments for renal impairment or hepatic impairment. Okay, this is a very interesting slide that I was very disappointed with because it made me sad that unfortunately we can't really play with the doses too much when we talk about the twice daily versus just daily. So they looked at 8 milligrams twice a day versus just taking it all at once, 16 milligrams daily, because we know with compliance, it's hard to get something in twice a day. Unfortunately, taking 16 milligrams daily just is not effective. You really have to get that 8 milligram BID dosing. And I was really happy they put this slide in, but this slide made me sad because that means that we really have to make sure our patients are taking it twice a day. It just won't be effective if they take it both at the same time, unfortunately. Okay, so how do we get this medication started? If you live in Kansas and everywhere else, you got to screen for tuberculosis. We're going to do a CBC to just baseline hepatitis screening, and then we have to do the CYP2C9 genotyping. We'll talk about that. You know, you can discuss with your patients whether or not they need certain immunizations, or go ahead and just recommend updated immunization, and then assess their lipids. So I do a baseline lipid panel because I have no reason not to. Some people, you know, you don't have to, and you could check it after you started the medication, but then how will I know what their baseline is and if this may be due to medication or not? So I just do it that way. Okay, so hopefully, well, I'm not sure how many of you have started LEQSELVI yet, but at first this was a huge burden in my office, and now it's nothing. Like all my staff is very up on how to do the CYP2C9 testing. It's literally not a burden at all now, but first 2-3 weeks, it was the thing. You had to teach everyone to make sure that, and now, okay, well, I would say now I don't even say any of this to my staff. They know automatically to do it. So I'll be like, okay, we're starting them on LEQSELVI. And I say nothing else. They know what labs to check. They know where to send it and I don't even mess with it. So importantly, for the CYP2C9 testing, it has to be sent to LabCorp. I have had, you know, it's all individualized. I literally had a patient last week. We specifically told him to go to LabCorp. He's a college student who does not have time to be jumping from labs to labs, but LabCorp said that they didn't recognize the tests, so they sent him to Quest. Luckily, Quest went ahead and took care of it, but try not to do that. So LabCorp has a partnership with Sun Pharma where they do it for free. And so unfortunately, I'm afraid that this college student will get billed for it because Quest is doing it, but I think he'll get billed for it. So this is free if they go to LabCorp. And I think in certain areas that might be a challenge because there may be not as many LabCorps, but where we are in Kansas City, we have not had a problem with it aside from that one patient. There is a test number, and it does depend on your EMR or EHR. The test number is this right here, the 512269. And that will make sure that they have the correct test. And so in our EMR, we do not have that pop up, and so we just cross it out and write it in. And again, I don't say anything anymore. Like the barrier at first, the burden at first to get this going was high. But now I just say, okay, we're starting on LEQSELVI, and I walk out the room and I do nothing else. They have it down. So just a little, it's just like, you know, when we started with iPledge back in the day, a lot of burden, but now it's like, you know, you start your patient on and you just move on. Okay. Oh, and the other thing is it does take a little bit longer to get the results than the rest of the lab work that you're going to be doing. So you'll have your CBC, et cetera, back probably before your CYP2C9. Okay, so, and the other thing too, I've been really impressed with the number of patients who have been denied by their insurances for LEQSELVI, but somehow they have the medication. So LEQSELVI support program is very good at bridging these patients. I will say I have not had a patient yet who wasn't able to get the medication somehow. And I'm not talking about samples, I'm talking about, you know, they were denied and they got on a program through LEQSELVI. So just if you are starting to use this medication or you want to prescribe this medication and you get a denial, just don't worry about it. Make sure you get through the support program and they will help you get the medication. So I've been really impressed with that aspect of it. We'll see how long that lasts, but you know, first couple months it's been going very well. So why would you do LEQSELVI? There are several other options. Okay, well, main answer is fast and effective, right? So fast, you know, we had patients that saw results in as little as 8 weeks, and that is huge. When you're going, you know, from this, look at this 8 weeks, you're happier, you're more optimistic, and you're very confident at this point. I love this video, it's very nice. And 1 in 3 patients did achieve near complete regrowth with a SALT score less than 20 within 24 weeks. And I think they're just kind of pointing to on the right that, you know, it's not just hair. Your confidence and your sense of self does fade with losing hair. So with LEQSELVI, you can give your patients the possibility of hair regrowth fast. Oh, I was premature with the video. There we go. Okay, that's all. Thank you. And then we'll go to questions.
So again, remember, if you want to ask questions to our faculty, please write in your questions on the right-hand side of your screen. And I wrote again a note there so you can write in your questions. Any additional questions can be submitted to info@idefeducationalseries.com after the presentation.
Can you hear me?
Oh, now we can hear you.
Yes. Okay, excellent. All right, so we're starting to get some questions in here. So let me just get started with the first one, Dr. Singh. So, okay, so the first question here is, all right, so there are, you know, 2 other approved JAK inhibitors for alopecia areata on the market. You know, what actually distinguishes LEQSELVI from the other ones? Which, you know, I think is a good question. You talked about why LEQSELVI, but you know, why LEQSELVI, or what are differences?
Mm-hmm. I mean, aside from mechanism of action, it's very similar to others that we have. I would say the rapidity of regrowth, the fact that they achieve statistical significance within 8 weeks is very interesting. And I really, really enjoy that data where it's not just focused on, okay, you met this clinical trial primary endpoint of 80%. The fact that they show, you know, how quickly they can get 50% coverage. And there was 20% of those patients, and this, you know, like I mentioned, these are severe alopecia areata patients. It's not like one patch here, one patch there. These are patients that are going to be challenging no matter what. We got 20% scalp coverage, I'm sorry, 50% scalp coverage and 20% of patients in 8 weeks. That's huge.
Yeah, no, I mean, the data are definitely very impressive. And, you know, I echo your sentiment. It's great that we have options, but, you know, when a new option, you know, comes up that's effective and, you know, really is, it is great from that perspective to have more options to treat patients. All right, so the next question here. So I actually like this question because it's kind of framing treatments or treatment decisions. I'm going to paraphrase a little bit of the question here, but it's phrasing the treatment questions from a perspective that I really like. I think a lot of people do this, which is, you know, to involve patients in the decision making about treatments, you know, quote unquote shared decision making. where we kind of bring patients in to figure out what the best path forward is, with different options. So with that in mind, what factors in your experience or kind of what you see do patients actually prioritize most when selecting treatments, including potentially with these JAK inhibitors?
Number one is safety, right? I mean, well, efficacy, of course, but when you get to that point, safety, right? Like, again, you can live without your hair, not that you want to, but you can live without it. Do we want to put a patient on a medication that is more harmful than the actual disease state that they have in the first place? So it's weighing that. I would say primarily, again, you have to be on these medications indefinitely until there's something better that comes around where you don't. And so the expectation is that you will be on this medication until you probably don't care about your hair anymore, which is probably never. And so we are going to be suppressing your immune system. Are you okay with that? That's the first thing that I think goes through the conversation with our patients. Some patients, we do feel that we really don't have a choice. Either we start you on these medications, which are the best opportunity to get the hair back, or you probably won't be able to get that hair back. I'm not talking about our severe alopecia totalis universalis that have had hair loss for 3 or 4 years, and this is the only thing we could possibly do for them that may actually have some kind of efficacy. So I would say those two things.
Yeah, no, I mean, I obviously completely agree with that. I think that, when treating alopecia areata patients, there are always going to be multiple factors that people think about, but people are motivated to get treated, with alopecia areata. I forget the exact quote you said, but I'll just, it's not just hair, and that really makes a big difference to people. And so getting their hair back, quickly but safely, this is kind of their lives that they have to live with. So completely agree with all that. And I guess to piggyback on that, maybe kind of like a different aspect, to what extent does that speed of response actually make a difference for patients? Like, do they care about that versus, other aspects about the clinical responses?
Mm-hmm. I mean, I think for ourselves and the patients, efficacy is going to be the most important thing. But I think for the burden of the psychological impact, speed makes a huge difference. We have our patients that you see no hair, and then it's like 9-10 months later they have a little bit, then it's like a year later, okay, we're seeing something. That's a long time to go. Taking a medication that's suppressing your immune system to get a little bit of hair or no hair, and you're just holding out hope. The rapidity of regrowth really helps with the stress and anxiety. You can imagine that if your stress is up here and you get an inkling of hope, little sprout coming out, you're like, okay, there's a chance. You're telling me there's a chance, right? I think that rapidity of regrowth, it just makes a big difference in stress and anxiety, and then just giving some kind of optimism to the patients.
Yeah, for sure. I mean, I think we know that no matter what, hair takes time to grow. So that's kind of the starting point. And, we always have the conversation with patients, counsel them, or, I shouldn't say we, I certainly do. Hey, it's going to take some time. And even when patients know it, and, when we know it, as doctors, it's challenging when there's no hair growth, because you have to trust the data that, people can respond later, but we really want to see that hair, and, the patient wants that hair even more so. All right, so I have a couple of questions related to the testing. So I'm actually gonna just, Yes. Yeah, so maybe this CYP2C9 testing, maybe you can speak I'm gonna amalgamate a couple questions here because they're asking about the testing. So maybe you can talk a little more, give a little more information about the test, and what is the screening you can do basically, or how does that affect the patient care?
Yes, so it affects it because if they're a poor metabolizer, then they're more likely, or they have an increased risk of some of the adverse effects, because it'll have a higher concentration, serum concentration, if they're a poor metabolizer. But like I stated, I've had some patients come back as intermediate metabolizers. That doesn't matter. It's just a poor metabolizer. And then with regards to checking the lab, like I said, LabCorp is going to be free for the patient. There are those carbon copy slips that you can use, that you can just request them from LabCorp, or you can do it through your EMR. And then, like I have to do, because I have EasyDerm, we just we write in the test code to make sure that they're submitting the correct test. But it really is very straightforward once you do it 4 or 5 times, and your staff does it 4 or 5 times. And like I said, now I don't even say anything. They know to handle it, because guess who gets the phone call when a patient is waiting for the medication, but they can't get it because they don't have that test back? It's not me. The staff is getting it. So it's easier for them to not have to answer these phone calls if they do it correctly.
Yeah, that definitely makes a lot of sense. Do you feel like, I mean, obviously there's a question of burden, like, is it a nuisance or not? It sounds like, I mean, for you, things have actually just not been at all. Do you feel like it adds anything?
100%.
Okay, well, no, but no longer. Once you figured it out, yeah. Do you feel like it adds anything to it, or is it just kind of like another hurdle to jump through, or?
It's just another hurdle. The likelihood that they're a poor metabolizer is slim to none, like 1 to 4%. But if that's what we have to do, that's what we have to do. But it's just like I was saying, like I pledge terrible. We all do it because we know that that medication is going to be more effective than what we already had them on. So we're like really motivated to go through this stupid iPledge program. It's kind of the same thing. It's like, how motivated are you to get this patient this medication? If you have a little bit more motivation to start this medication because maybe they failed something else, that like little bit of a hurdle you'll get over. It's just, you got to get into it, like try it a couple times, and then it'll be nothing. But we were complaining like crazy before. Like we were complaining. It wasn't like, oh yeah, it was a lot of complaints, but we got to know.
No, it's true. And I mean, I think a lot of dermatologists don't love checking blood work about, for anything, but there are certain things you kind of get into I think the habit or routine, and, we can grumble about it, even though it ends up adding or kind of, crossing the T's and dotting I's on what we need to. And then I think we have one more question here, going back to the speed. So, so in the trials, and I suppose, I'll kind of ask if you mentioned one patient, but if you're seeing any kind of correspondence in real world data, but how quickly did patients respond? And I guess probably the primary endpoint of that SALT of less than or equal to 20 in the clinical trials, how quickly did they respond?
So it was only about 3% that actually achieved that SALT score of less than 20 in 8 weeks. But, a third achieved the SALT score less than 20 by 24 weeks. It's 6 months, which again, this is a very challenging group of patients to treat. But I just thought it was so promising that it was literally 1 in 5 that had half their hair back within 8 weeks. 8 weeks is nothing, like we can all wait 8 weeks. Have we ever cut our bangs and then to here? It takes 6 months to get it to here, right? So 8 weeks is nothing. So I think that rapidity was just so impressive, and is, in my opinion, a game changer for every aspect, from psychological to actual, cosmetic coverage and how patients present themselves.
Definitely. I think, one of the, as I mentioned before, I think even just depending, obviously people are going to have different timeframes when they see patients back and have follow-ups, but, having a patient come back with some hair growth earlier on just makes that visit so much kind of more positive and easier. And so patients, they want their hair tomorrow. Well, no treatment's going to do that, but, if we can get treatment, ultimately, like you said, that efficacy, getting all the hair back. But if we can do that sooner, then I think that's obviously something we should all aspire to.
Absolutely.
All right, I think that's all the questions that I have here, essentially. So.
Well, thank you.
I'd like to thank your supporters again, Sun Pharma, for making this educational event possible. And now that this program is complete, please tune in this Thursday, October 9th, where we're going to be talking about advancing patient care in vitiligo. Dr. Eric Dominguez is going to be talking with his patient, Erica Page. Thank you so much, Dr. Singh and Dr. Unger, for this wonderful presentation and this educational event that really highlights one of the great therapeutic options, new therapeutic options for patients for alopecia areata. And thank you all for joining us this evening. Good night, everybody.
Good night.
Take care, everyone.